Our presentation is on the methods and rationale for wound bed preparation. By definition, wound bed preparation is the management of a wound in order to accelerate endogenous healing or to facilitate the effectiveness of other therapeutic measures. The concept focuses on the clinician to optimize conditions at the wound bed, so to encourage normal endogenous healing. It is an approach that should be considered for all wounds that are not progressing to normal wound healing. In order to investigate the process of wound bed preparation, we must follow the pathway as per flow. Wound healing is a complex series of events that are interlinked and dependent on one another. Acute wounds usually follow a well-defined process described as coagulation, inflammation, cell proliferation and repair of a matrix, as well as epithelialization and remodeling of scar tissue. In the past, this model of healing has been applied to chronic wounds, but it is now known that chronic wounds heal in a different way to acute wounds. Chronic wounds remain in the inflammatory and proliferation stages of healing for a longer period of time, which delays closure. The epidermis fails to migrate at the wound margins, which interferes with normal cellular migration of the wound bed. In order for us to determine appropriate wound bed preparation, there are a number of protocols we must follow. In order to select the best type of wound bed prep, it is important to conduct a wound assessment on the patient to determine the type of wound and the most suitable way to manage the wound.
There are some immediate considerations when assessing a patient for the first time. When looking at the wound, we have to consider if it needs revascularization, so we could send it off to a vascular surgeon. Perhaps it needs surgical debridement, so in that case we'd send them to a plastic surgeon. If they need help controlling their diabetes, we can send them to an endocrinologist. A GP for medication if the wound is infected or showing any signs of gangrene or necrosis. And then we move on to basic wound management, where we have to start considering an aim, whether we're going to start encouraging healing or trying to stop the wound from progressing or deteriorating. Our basic principles of wound management include cleaning the wound, dressing the wound, changing dressing and reviewing it appropriately, and referring on when required.
Ongoing management consists of regular wound inspection and cleaning, removal of surface debris, and protection of regenerating tissue from the environment, along with managing systemic conditions. Inappropriate management of wounds can lead to delayed wound healing, deterioration of wounds, and wound breakdown. Wounds should be carefully reassessed with every dressing change to ensure the most appropriate products are used. The etiology of the wound must be addressed, such as managing diabetes, peripheral vascular disease, and foot deformities. This can be done by ensuring adequate blood flow and monitoring high-risk regions and blood glucose levels. The wound should be cleaned regularly with water or sterile saline. After this is done, exudate should be controlled in order to maintain a moist environment. Hydrogel is a sterile inert protective dressing which maintains a moist, occlusive environment for the wound. It is safe as it uses the body's own defense mechanisms, such as macrophages and neutrophils, to clear devitalized tissue. Hydrogel is contraindicated if there is excessive exudate, infection, or critical limb ischemia. If hydrogel is not used, then it is recommended that scalpel debridement take place in order to clean the wound. Offloading the wound with padding or a total contact cast may be beneficial, as there will be patients with foot deformities and high-risk regions. Padding reduces shock attenuation, shear and compressional forces beneath the high-risk regions and the wound. If ongoing assessment fails, and wounds are not progressing through the normal stages of healing, focus should then be shifted from the wound itself to underlying cellular abnormalities and other associated clinical problems. This can be achieved via wound bed preparation principle. The wound bed preparation is a systematic approach that removes barriers to effective healing. These are tissue viability, infection or inflammation, moisture balance, along with wound edging. Tissue viability refers to the removal of non-viable tissue such as slough or necrosis for promoting healthy tissue and a well-vascularized wound bed. It is theorized in order for a wound to heal completely, blood supply must be adequate and healthy tissue must be present via removal of necrotic tissue. This can be achieved by debridement, which is widely used to remove non-viable tissue. Debridement can also reduce wound contamination, thus reducing tissue destruction for promotion of adequate wound healing. There are 5 different types of debridement: autolytic, sharp surgical, enzymatic, mechanical, and biological agents. The effect of this is to restore the wound base and to allow a fully functioning extracellular matrix. The clinical outcome to be achieved from this is a viable wound base for adequate wound healing. In a bit more detail, autolytic debridement is used of dressings such as hydrogel to use the body's own defense mechanisms to clear devitalized tissue. Sharp surgical debridement involves the use of a scalpel to debride devitalized tissue to expose healthy tissue. Enzymatic debridement is a process that uses chemical enzymes to break down eschar formation. Mechanical debridement uses wet dressing, which softens dry tissue. When the wound rehardens, it sticks to the dressing. Upon removal, the devitalized tissue is also removed, and the healthy tissue is then exposed. Biological agents such as maggot therapy use maggots to digest necrotic tissue and pathogens. Prior to debridement, specialist advice should be sought in order to conclude which method is best for the patient. Specialists include tissue viability specialists or a wound care specialist. Infection and inflammation in the wound base can cause discomfort, pain, and prolonged wound healing. Signs and symptoms of superficial wounds are non-healing, increased exudate, and bright red granulation tissue. Deep tissue infection is characterized by pain, increased size, and erythema with exposed bone. When assessing a wound bed for infection, the following should be monitored: high bacterial counts, increased inflammatory cytokines and protease activity with a decreased growth factor. A wound bed can suffer 2 types of infections: acute and chronic. Acute infections is when there is increased blood flow to the region via vasodilation. This process removes microorganisms, foreign debris, bacterial toxins, and complement antibodies. This activates the coagulation cascade, which isolates the site of infection and protects the host. In chronic infections, there is a prolonged inflammatory phase, which leads to host and cell injury. Due to the large bacterial colony, along with prolonged inflammation, the body's natural autolytic function is disabled, thus leaving non-viable tissue. Method of treating this infection should be used along with wound swab to isolate the exact bacterial specimen. Debridement of devitalized tissue, wound cleaning, and the use of topical antimicrobials with silver dressing should be used prior to antibiotics. If infection persists, systemic antibiotics are then used. However, caution must be then taken to avoid bacterial resistance. Agents such as iodine and silver preparation have been shown to be bactericidal to multi-resistant microorganisms. However, for chronic infections, antibiotic therapy must be elicited.
Part of preparing the wound bed includes ensuring the moisture balance is adequate to encourage healthy wound healing. A dry wound can be painful, itchy, and delay healing by impeding epithelial cell migration. Furthermore, it can result in a reduced cosmetic outcome. When a wound is wet with exudate, it is important to note whether this exudate is healthy or not. In an acute wound, the exudate has a positive function. However, in a chronic wound, the exudate changes in volume, odour, colour, consistency, and can in fact become corrosive in nature and result in damaging the surrounding skin. Therefore, when preparing the wound prior to dressing, consideration must be given to whether extra moisture is required or whether moisture needs to be absorbed. Consider whether interventions will be added to the wound bed prior to dressing or whether they will be incorporated into the dressing. There are a number of choices of dressings available depending upon the extent of wound moisture. The final stage of the time principle involves assessing the edges or borders of the wound bed or assessing the epidermis and whether cells have been migrating, depending upon which author you refer to. If it is determined that there is an issue with the wound borders or cell epithelialization, it should be determined what may be causing this so that appropriate measures can be taken.
If a wound has progressed to normal stages of healing, the current treatment plan should be continued. Regular vascular assessment should be done in order to continually assess if the wound has adequate blood supply required for healing. If there is any devitalized tissue, debridement should be also continued to ensure that healthy tissue is present to ensure the wound continues to heal normally. Regular checkups along with regular dressing changes should be done frequently until the wound heals completely. As mentioned before, the type of dressing depends on the wound and patient's needs with specialist considerations. This should also be done with regular checkups and follow-ups for the patient to ensure that the wound is healing correctly. If a wound fails to heal, there will be large amounts of non-viable tissue, infection, and the type of dressing would have been poor, with increased or decreased moisture availability and poor circulation. As there are various reasons as to why a wound may not heal, it is important to reevaluate the time management principle and the current management plan itself. Reduced blood supply, in this case, can have poor vascularity. A referral to a vascular specialist may be beneficial for the patient. The possible use of resources such as an angiography or a transcutaneous oxygen tension can be used to assess the patient's tissue healing capacity. Advanced techniques are used when a wound bed fails to heal and are used in extreme cases. The following advanced techniques are all effective in non-healing wound beds: autologous skin grafts, grafting using cultured cells such as keratinocytes, bioengineered products, allergenic bilayer tissue, and artificial skin. In addition, a number of growth factors have been developed which are usually supplied in mesh that is supplied over the surface of the wound. Data on the performance of these growth factors have been emerging over the last decade. Basic fibroblast growth factor stimulates endothelial cell proliferation and migration. Transforming growth factor stimulates the growth of fibroblasts and keratinocytes as well as the production of extracellular matrix, and particularly collagen fibers. Endothelial growth factors support growth keratinocytes and assist the migration of keratinocytes, fibroblasts, and endothelial cells to the wound. Platelet-derived growth factor are chemotatic for polymorphonuclear cells and macrophages. Thank you.